Okay, good morning. So in an effort to start on time, welcome to the next session. This is presented by the International Uveitis Study Group on multimodal energy and non-infectious posterior uveitis, or NIPU. And want to acknowledge my esteemed chair, Vishali Gupta, sitting in the front row here. And we have a series of talks. Unfortunately, Ali Uveitis was not able to join us, but his talk has been loaded, and we'll play that for you so that you're not missing anything. So I am the first speaker, and I'm going to talk a little bit about characterizing non-infectious posterior uveitis. Thanks. Nope. There we go. Okay, so here are my disclosures, and they are not specifically related to this talk. So the non-infectious posterior uveitis consist of a variety of diseases listed here on the left that have been previously described as white dot syndromes. The problem with this is that the majority of these diseases are really not white. The chorioretinal lesions are a variety of different colors with a variety of different pigmentation. And they're not all dots or spots either, serpiginous being kind of the obvious one, that the lesions are windy and snake-like or almost amoeboid. And so trying to characterize these diseases or describe what phenotypically you see is something that we've been working on for the better part of almost 2 decades now. And so I'm going to kind of tell you a little bit about where we sort of started, and then the other people are going to talk about more things having to do with imaging and how you could characterize these diseases and hopefully distinguish one between the other. So some of this work started with something called the Standardization of Uveitis Nomenclature, which is a group of uveitis specialists that were tasked at trying to define different types of common uveitic syndromes. So we have about 6 or 7 of these so-called white spot syndromes that we now call non-infectious posterior uveitis, because it's as good as a descriptor or better descriptor than white spot syndrome ever was. This project began about 17 years ago, and the idea was to build consensus so that people understood that we were sort of all describing a similar disease, or at least the more typical
Good morning, everybody,
so
and
that we could,
thanks.
Do a better job of defining outcomes, how to monitor the diseases, how to incorporate this into research. So this had 5 different phases, which are listed below, and the publications that came out of this were about 28 publications that were published in the American Journal of Ophthalmology in 2021. So with posterior uveitis, having imaging can be incredibly helpful. It allows you to sort of see things in real time, think about the disease. You may not always notice every nuance of a disease when you're looking in on your clinical exam, but having a fundus photograph or that fluorescein may add to your understanding of really what you're looking at, whether it's active or inactive, and help you decide what you need to do with treatment. So with Sun, we collected images, although the main goal was to actually develop descriptors, or sort of common language, to describe what the lesion that you're looking at looked like, how much pigment was there, what location it was in the retina, the choroid, or a bit of both. And we used this. We used the images to sort of corroborate this, but even if the images were not available because people were kind of using these agreed upon language, you could still enter cases into a database for subsequent data analysis so that we could reach consensus on these classifications of these diseases. We were very kind of particular about what images you had, so some of the other people that are going to speak are going to give you an idea of the advantages of having a complete set of images. But in this case, because these were collected after the fact, you didn't always have the images. But what we tried to do was say, if you've got chorioretinal lesions, please give us a fundus photograph to show that, or a fluorescein, or a fundus autofluorescence. If you have a case that you believe is retinal vasculitis, please show us your fluorescein angiogram, and so on. Again, because we were dealing with largely clinical data, even if we didn't have all the images, we would have sort of the gradings of those images. So what the clinician thought they saw in the images. And we presumed if the image was not available, that it wasn't necessary to make the diagnosis. So in other words, perhaps you didn't need the OCT to diagnose retinal vasculitis. You might have only used the OCT to decide whether or not there was macular edema there, but you didn't necessarily have to upload that in the database, because the database represented 7,000 cases, and this was people all over the world volunteering their time to enter this information. So we tried to make it as user-friendly as possible. And we had historical data in these cases as well. The tough part was the disease wasn't always necessarily active when you collected the case, okay? And so you'll hear from others like Dr. Ganga Putra that sort of these multimodal imaging helps us determine active versus inactive, which is a layer that goes beyond what we were doing with the SUN project. We did a series of case selections. So for posterior uveitis, this was 250 cases of each of the diseases. And you went through and you reviewed this in committee with a group of about 10 of your colleagues. And then there was a formal Delphi technique or a nominal technique where everybody got to say sort of their 2 cents of whether or not they agreed this was a case or not. And if there was a consensus of a supermajority, which is more than 75% of the people said, yes, in fact, I believe that this is a case of birdshot, then that was sort of a case, so that was passed. If it was less, then there was adjudication, more discussion, and if possible, they tried to come to a supermajority agreement of what a case was. If the case was there was no supermajority, then that case was essentially thrown out of the database. So the database was comparing cases where the majority of uveitis specialists said this is in fact birdshot or this is in fact multifocal choroiditis. And then they were compared disease to disease, okay? So machine learning, now you have a bunch of cases of the 6 or 7 different non-infectious posterior uveitis. You also had infectious posterior uveitis that went into the database. And then what we did was compare them disease to disease to generate a list. The computer generated a list of these sort of descriptors. Which factors are really, really necessary for somebody to say, aha, that's a case of birdshot and not a case of PIC, okay? There were no normals. Okay, so just the disease entities here. And so, but you don't really need normals if really what you're trying to do is you're trying to say these are the specific factors or features that you see in a case where the experts agree that that's a true case, okay? So you don't have the normals, you don't have the negative set, okay? And that's why you can get away with this type of looking at these different diseases. All right, so there were a total, so it started at about 7,000 cases. They narrowed to about over 4,000 cases. That included all different anatomic locations of uveitis and non-infectious and infectious. When you looked at just the posterior uveitis, it was 1,068 cases. So 85% of that was used as a training set. That's where you're teaching the computer what's important. and then you've got the remaining 15% which you hold aside, and then you use those to try to validate. So in order to prove, did the computer get it right, or did the computer just completely miss this up? Okay? We use something called evidence for because you've got a small number of cases with a lot of different variables. So sometimes what you ended up doing is combining variables. So in other words, for PIC, the computer thought it's important for these lesions to be small, okay, under 100 microns. And it's important for the majority of them to be in the macula. So they combined or engineered these combined features so that you didn't have 1,500 some odd variables that you were trying to cross-reference, which makes it very hard to do with kind of a standard machine learning capability. We're getting to the point now where we can, we can look at terabytes and terabytes of stuff. If anybody's familiar with the foundational stuff that they use the fundus photography, and they say, is this person a man or a woman based on the retina? That's terabytes and terabytes of data. That's not this, because uveitis is a rare disease, so you kind of get what you get, okay? When we looked at accuracy, the accuracy for these cases were quite good. If you see, we looked at 9 diseases, so it was the 6 non-infectious and 3 additional infectious, and the accuracy was 98%, and you see the confidence intervals there that are still fairly tight. So good, strong result. All right, so now what are we doing? Well, now we're moving into MOVE, okay? And so this is the multimodal thing. So now we've got kind of how we want to talk about these diseases. Now everybody's collecting these prospectively acquired data sets, active disease, inactive disease, multiple photographs. And this potentially allows us to kind of dive deep down into what are you seeing on those images that distinguish the two. Provides for a better data set, a longer lasting data set, gives you ideas on how to monitor the disease, what is active, what is inactive, and potential for extra research. So in summary, the start of this was to define the typical case and to define the verbiage in order to describe the cases. And this worked very well. It's got good performance both clinically and translationally. But this now becomes that scaffold about what you're going to hear about next, which is the multimodal imaging that's really kind of the crux of dealing with these diseases. And I think the next person, we're going to do Sapna, yep? Okay. Thank you.
Thank you very much, Jennifer. Our next speaker, we're going to switch a little bit the order. We'll keep the taped presentation for the last. And the next speaker will be Sapna Gangaputra, and she'll be talking to us about imaging biomarkers differentiating between active and inactive lesions.
How do I give mine?
No.
Us wale pe.
Thank you so much. Thank you for really to the organizers of APAO and most importantly IOST and Vishali for having me here. Thank you audience for being here to listen to this. And thank you. What I'm going to be talking about is builds up from what Dr. Thorne just said. So we started with SUN 2, and really good clinical data about how we should define diseases, classify diseases. But as she mentioned, the imaging part of that was reliant on what the physician said that there was. They didn't really do a lot of deep dive into how does imaging really help consolidate this, how do we really differentiate between active and inactive. And so then what we did was we started talking about MOVE, which is multimodal imaging in uveitis. And for this, what our goals were, overarching our goals were, is to identify diseases, and we started with diseases that had good imaging. So we started with posterior uveitis, and we're going to look at the posterior uveitis categories that we can look at multimodal imaging and build upon SUN. We did not want to recreate the wheel. We did not want to start fresh and say, let's look at some new classifications. We're going to stay with that, but we're going to use imaging to help us understand a few things. What is the best imaging that one needs to diagnose one of these posterior uveitis. What if I have a patient come into my clinic and I have a clinical suspicion, which imaging will really help me get that diagnosis? Now I'm following this patient in time. What is the best imaging I should use for this patient that will help me monitor this patient? So how will I know that, oh, this is a relapse now, without waiting for, because yes, you know, posterior uveitis, patients don't complain. You know, the anterior uveitis, they have a red eye, they're symptomatic. With posterior uveitis, there could be active lesions that are not identified, and many times they see us and we are the ones who say, wait, this is active. We need to change your treatment plan because this is not working. And so that, and then the complications. Whenever there's posterior uveitis, you can have complications, most commonly cystoid macular edema, CNV. How do we monitor for this? Most of us will use an OCT, but is that the best? Is there something else that we could use? And this is what we did in our study. We tried to build upon these three. So we set up 5 committees led by Dr. Gupta, Vishali Gupta, and Janet Davis, and then we selected 5 people who would lead on these 5 disease entities. We chose these because they were most commonly referred to as a basket of white dots. You know, anybody who has AMPI is called white dots. But we know that maybe with imaging, we might be able to separate out these white dots and not put them in one basket, but have a very clear diagnosis and a much better definition for each one of them. So I was leading the multifocal choroiditis group, so I'll talk a little bit more about that one. So as I mentioned before, I'm not going to belabor the fact. With Sun, we used that as the foundation blocks. We did not change that. Everybody had to have no infectious disease. That had to be ruled out. You had to have a clinical appearance that matched Sun for a multifocal choroiditis. So that was a non-negotiable. And then what we did was we collected together a committee of people, because this shouldn't be my opinion or your opinion. We have to have a consensus where the uveitis community, the retina community, can come together and agree with something. So we very selectively chose people. We were like, let's take medical retina people. Let's take surgical retina people because they see these patients. Let's take uveitis because we treat these patients. Let's take imaging experts because imaging is evolving. We need to understand what's happening. They may have a better understanding of it. We took methodology experts, and then we made all these people into groups. Then we had actually the most time-consuming task was finding the cases, because even in my clinic, I might see a birdshot patient, but I may not get an FA at that visit. I may get an ICG one time, I get an FA to make life easy. So we had to find patients who had the entire spectrum. They have to have Sun qualified diagnosis, and then they had to have color photos, and they had to have autofluorescence and OCT, ICG, OCTA. So we wanted to collect all of that. So we searched, and we did not focus on numbers. We didn't want large data set, but we wanted perfect data set. So we then cleaned up these data sets, chose the ideal ones, decided that now we have a good set, and then we had multiple rounds of review where we looked at them and say, does this look like multifocal to you? What do you think? What do you think? Then we kept closing in until we found a group of set of images that we all agreed this was multifocal or this was PIC. Then we started to refine it further. What characteristics on the color photo looks like MFC? What characteristics on the OCT look like it? How do you know this is active? How do you know this is inactive? Let's try to work through it. And so we went to rounds and rounds and rounds. Then we had voting in that group. And then we decided, okay, this we agree, and I'll show you the images as we go. I'm just covering the methodology here. And then remember I told you we have 5 committees. So once we made our decision in our group, then we took this and we went to the full group, all 5 committees, which each had 8 to 10 people in it. And we said, okay, now here's what we recommend. Do you agree? And then we took in all their recommendations, whether they agreed with our recommendations or not. And then last of all, we went to Inflammasio in Singapore, and then we actually polled a whole room of 200 people. Dr. Gupta is going to talk more about that section. I'll come back and talk about MFC. So here's a color photo. And we found that, especially with multifocal choroiditis, a clinical exam or a photo can really give you a good idea of what the diagnosis is. In that, yes, there's multiple foci of lesions, multifocal, right? And then we found out a little bit more definition. If the edges are very sharp, is there a pointer here? It's okay, no problem. If we find that you have like very sharp round edges where you can see the end of it, that looks inactive. If the edges are a little fuzzy, that's suspicious for an active lesion. And as we go, I'll keep showing you more images. This is a PIC. Now again, remember Dr. Thorne said, small lesions more in the posterior pole. Thank you for the pointer. And you can see here, small lesions, inactive in the posterior pole. I showed you a wide angle optos, so you can actually see that there's no other lesions anywhere else, but you can have it. But they're small, discrete, and pigmented, inactive lesions. If they're active, they're a little bit more fluffy, they're a little bit more creamy yellow in color. There were some other things in literature that people have reported, but we didn't find it consistent. It's called Schlagel's lines, peripapillary atrophy, and we also find that, most of these patients are myopes, and myopes may have those findings in general, and so we decided it was not specific enough for multifocal or PIC, so we did not include that. And we've all looked at this when we were young. I still look at it, like how do you find 10 differences between the two pictures? So we try to do that, like is there a difference in multifocal choroiditis and PIC? Is it just lesion size? Is it location? Is it behavior? And what we found was that phenotypically they are different. As I said, big lesions, maybe small lesions, periphery, maybe more focal, but most importantly, when you're actually looking at how do they behave when there is activity, it was exactly the same. So an active lesion on PIC versus an active lesion on multifocal was so similar that the rest of the imaging that we looked at, we almost group them as the same. So when I'm showing you images, some may be PIC, some may be multifocal. I have obviously selected the better looking photos to show you, and so because I want it to be very classic. So on OCT, here's an example of an OCT image that shows an active lesion. And you can see on the SLO image, you can see all these lesions, and there are these like little spots here, and then down here you can make out this one is probably more inactive, this one probably looks a little bit more active, but the OCT shows you for sure that when it's active, there's that fuzzy subretinal hyporefractive membrane, like a little puff. We don't have a good word for it, where that may be the next step. Well, like how do we define this in medicine? We always choose food to define things, so maybe we'll come up with something, but as of now, we're calling it fluffy subretinal, and you can see how clearly that is not the same as the rest of the ellipsoid zone, and there's a big break in the ellipsoid zone. So that's why our patients are they notice it. They notice that there's something missing. There's a scotoma. They notice it. And when we look in them clinically, it looks like small lesions, but the impact area is probably bigger. And here's another set. You can see active images on the top, and in the bottom is inactive images. Same here, active, you see that fluffy membrane on the top, and in the bottom, there's that either that ellipsoid zone is thinned out or it becomes into a little scar. The ellipsoid zone may or may not fix itself. Sometimes the ellipsoid zone regenerates, sometimes it doesn't. And I've also mentioned here, there is focal choroidal thickening. These are myopes. You can see how thin the choroid is even in the inactive images in the bottom, but on the top images, you can see that there is a focal thickening of the choroid right under the lesion. And that's a very good sign. I've actually, now that I know this and I'm seeing it in my patients, sometimes you'll see the choroidal thickening even before the lesion becomes so apparent. So for my patients with multifocal and PIC, I am now getting more of the EDI OCTs because I'm monitoring them more using that. And here I just want to show some more examples of the ellipsoid zones reconstituting. What about autofluorescence? We always talk about autofluorescence being such a good tool for measuring choroidal lesions. And this side image was a patient of mine who I had seen just a few months ago. I got photos, and you can see these lesions up here. You can see how they're dark spots because those are inactive lesions. So when there is loss of the RPE, you see a hypo autofluorescence. That means that it is inactive, dead tissue, so to speak. And so this is a completely inactive eye. And then the patient presented back, and you can see in that same area with the red arrows, there are white dots there now. And the important part about that is because when there's inflammation, these photoreceptors, the RPE is getting triggered, lipofuscin is liberating. And so it's like a small box, the RPE. And when it's irritated and inflamed, it pops open and lipofuscin escapes. And when that escapes, you see all this hyper autofluorescence, and you can see it up in that area there lighting up. But I do want to make a point here. If I had only got OCT on this patient, I would have seen nothing because there was nothing at the macula. So this was helpful for a monitoring tool based on where the lesions are. Second point I want to make, even here, this picture is showing much better than this picture that I am looking at. So be very mindful about your screen that you're looking at. There might be imaging artifacts that may block things. Color contrast of the photo may be off. So some of the things I want you to be a little mindful of. And so clinical correlation is required whenever you interpret these images. But autofluorescence, ultra wide, especially if your lesions are peripheral, is really very beneficial. Can I keep going? I won't take longer.
Of course, please do.
Thank you. And this is another one point I want to make about fundus autofluorescence. Sometimes when you see the lesions, they may have a ring of hyper autofluorescence around them. This is not activity. This is just that lipofuscin pushed aside, and it can remain permanently there. So activity is diffuse lesion of hyper-autofluorescence, ring of hyper-autofluorescence with hypo-autofluorescent in the center is still inactive lesions. So keep that in mind when you're monitoring the patients. Fluorescein angiogram, wonderful tool. We use it a lot in retina and uveitis, but for multifocal lesions, you may see disc leakage if there's inflammation. You may see leakage from the lesions, but we did not think it, and of course CNV, but we did not think it added very much more in the monitoring or the diagnosis of multifocal choroiditis, because if the lesions are hot, you can see that on the OCT also if it's in these tractable areas. Same with ICGA. I don't know why the pictures are not showing, but same with ICGA, we did not feel, you can see new lesions that come up that can show you, I'm so sorry, I don't know why it's not showing, but you'll see more lesions in ICG, and they become, just that can show you as a good monitoring tool if your FAF, your fundus autofluorescence, or your OCT does not show it to you.
We all know that
also not showing, OCTA is a non-invasive, really helpful for monitoring for CNV. But not, nothing is there a problem with my slides loading?
Chamber and vitreous A's.
Okay, so we make those recommendations that OCT is really helpful. Color photographs can be used as clinical exams, so not very much useful. Fundus autofluorescence, very, very beneficial. And then when we sent it to the entire group and we asked them to vote, you can see here that OCT and autofluorescence got the highest level of consensus, that that's what you would use, but all the other things got lower consensus, pretty much similar to what we had said. And so, we're scientists, we never stop learning, we never stop asking questions, we never stop moving on. So what do we need? Even if one lesion is active, that eye is active. So how much are we going to track each and every lesion? And Dr. Vishali asked this really nice question. What is minimal residual disease? What is that threshold? When should we act? It's like when we see patients with anterior uveitis. If you see 1 or 2 cells, should you treat? Can you wait? Can you just watch the patient? And then imaging technology, every day it's evolving. You walk through the show floors and you get a headache because you're like, I just bought that OCT. Do I have to buy another OCT? And so, we are also learning. Imaging is learning. Things are evolving. Whatever we say today in 10 years is obsolete because something else has happened. The new kid on the block is more valuable. So for now, we're presenting these, and we hope that everyone can use this as a guide to diagnose and monitor and look for complications in MFCPU and PEC. Thank you. Feel free to email me if you have any questions. I'm always happy to talk. I'm especially happy to answer questions on this topic. Thank you.
Okay, so we're again going to switch the lineup just a little bit and welcome Vishali Gupta, who's going to talk about minimal imaging criteria for the non-infectious posterior uveitis.
Thank you, Jen. Thank you, Mark. Thank you, AIOS and all the members for this beautiful project. So can I have my slides, please? Perfect. So we heard the previous 2 talks. Jen beautifully told what sun has done for uveitis. It standardized the nomenclature, but it did not standardize the imaging language and we are in the era of multimodal imaging. So what we decided was to standardize the imaging language, and to begin with, we just chose 5 diseases. Okay. Non-infectious posterior uveitis. We chose these 5 diseases because they have been clumped together as white dot syndromes. And like Sapna said, they were dumped together because we did not want to differentiate one from the other for the sake of convenience. But they are not the same. Some of them need treatment, some do not need treatment. So we decided to get away with the term of white dot syndrome and to identify each one of them separately and put them as non-infectious posterior uveitis. And the studies which we studied included mutes, serpiginous, birdshot, ampy, and multifocal choroiditis. So I shall be talking about minimal imaging set. And for those of you wondering what is minimal imaging set, it's the kind of that everybody doesn't need every lab. Similarly, every patient of uveitis does not need everything in imaging or multimodal imaging. Sapna showed beautifully that for multifocal choroiditis, probably all we need is a color photo, OCT for activity, and autofluorescence to look for near lesions. You do not need everything for everybody. So we wanted to define it, what experts think would be the minimal imaging set for these entities. It was a complicated process, and I'm not going to talk about how we did it because Sapna has explained beautifully, and this is how we decided. So we had committees. Each committee was given a task, 2 tasks. One is to generate the clinical utility statements. For example, what is the role of ICG in multifocal choroiditis? Does it have a role? And if the role, what is the clinical utility? And the second was to give us minimal imaging set. Each of these entities, what is the minimal imaging criteria the experts feel should be done? So I'm going to talk about minimal imaging set for these 5 entities one by one. All these reports have been submitted for publication, and I'm very thankful to all our contributors who have spent a lot of time in showing what I'm doing today. So let's begin with serpiginous choroiditis, something we see very commonly out here. So the first question, when you see a patient and the color photo or the clinical exam is equivalent. So you look at the image and you ask yourself, well, it looks like a serpiginous choroiditis, and you are quite confident, well, this is serpiginous choroiditis. Yes, you do not need any multimodal image to tell you whether it is serpiginous or not. Clinical examination and color photo are enough. Well, you say yes, it is serpiginous choroiditis. The next question you ask yourself, is it active or inactive? To determine the activity, the minimal imaging required is autofluorescence and OCT, not fluorescein, not ICG. So, and both of these are non-invasive, and this is something majority of the comprehensive ophthalmologists have it these days. In the autofluorescence, you look at the edges. The edges are hyperautofluorescent. It means the disease is active. If everything is dark, it's inactive. You look at the OCT through the active lesion, which shows hyperfluorescence in the outer retina, again indicative of the active lesion. This is the autofluorescence of inactive, which is totally dark. And this is during the follow-up. You can see these hyperreflectivity in the outer retina is gone. And what you have is a kind of the scar. This is inactive. So you do not need any invasive investigation. During the follow-up, Sometimes in the scar there can be development of choroidal neovascular membrane, and if you want to see that, it is angio-OCT at that particular time. The other is you look at this clinical picture and you're not sure whether it is serpiginous, is it AMPI, is it something else. That is the time you would do fluorescein and ICG, because you want to differentiate serpiginous from AMPI or other things, not for anything else. So this was the minimal imaging criteria regarding serpiginous. And then we come on to the next entity which Sapna has already described, and I will show you in one slide, multifocal choroiditis and PIC. They both have been clubbed together because it's believed they are spectrum of the same disease. So you look at the color photo, you can make the diagnosis. You do not need imaging. So color photo and clinical exam is enough. You want to know whether the disease is active or not. You do OCT through the lesion. You see the shrum which is fluffy, the disease is active. You can do autofluorescence, hyper-autofluorescent lesion, the disease is active. Well, you are monitoring. If you are monitoring for reactivation, autofluorescence is a good modality to show hyper-autofluorescent new lesions or sometimes late phase ICGA. But if you are monitoring for choroidal neovascular membrane, it's angio-OCT. Now, what is the role of fluorescein and ICG? Virtually to show you the extent of the disease, nothing more than that. Coming to the third, this which we talked about was about MUDs. What are the minimal imaging criteria? And we are now seeing quite a few number of patients with MUDs, especially in the post-COVID era. I don't know why. The first question when you look at the color photo, you ask, is it MUDs? Do the autofluorescence, because autofluorescence is one which will show the characteristic feature and you will come to know, well, this is MUDs. OCT, again, you can do, and in OCT, the sparing of the choriocapillaries and choroid actually favors the diagnosis of MUDs. Now you have looked at the color photo and autofluorescence and you are quite confident that this looks like MUDs. Well, it is typical for MUDs. Nothing more is required to make the diagnosis. And if you want to monitor the resolution, you can do the autofluorescence. All these granular white appearance, they will just disappear because MUDs is one-time event. So you don't have choroidal neovasculars appearing or you don't have to monitor. It's one-time event, it will disappear. You can just do color photo and autofluorescence. The second thing is you're not very sure it's MUD, not very typical, and there is something called epi-MUDs, which is a secondary MUDs and other confusing thing. Then you do the fluorescein, ICG and OCTA to differentiate it from other entities. Coming to AMPI, and there has been a lot of overlap between AMPI and serpiginous because AMPI might begin as AMPI and get into serpiginous. We are not talking about the transition, we are talking at presentation. So if you look at the color fundus photo for morphology, you can say it's AMPI, but not with that much confidence as you will say multifocal or MUDs. So you need fluorescein even to make the diagnosis of AMPI. The spots which are hypo and which become hyper. You need ICGA and OCTA to make the diagnosis of AMPI because the areas of choriocapillary non-perfusion are requisite for making the diagnosis of AMPI. So you will need these investigations right in the beginning. Then comes whether this AMPI is active or not. Of course, you can do it on fluorescein, hypo to hyper, but this is very typically OCT through the lesion, which shows activity in the outer retina and then resolution. And last is birdshot. Birdshot was a different thing altogether. Color fundus is enough, but you required ICGA to differentiate whether it is acute or chronic, whether it is active or inactive, and even for monitoring the bird shot, ICG and fluorescein were required, whereas none of other white dots required ICG to monitor response to therapy. So these were the 5 minimal imaging sets which were given by our committees, but we did not just want them to be released like this. We wanted to validate it in the real life, that if I present it to you, will these stand the test of the time in simple words. So what we did is we had about, during the live meeting in Singapore, we presented mix and match of these criteria in a very methodological way, and we asked people to vote for the minimal imaging criteria. We had 156 ophthalmologists who participated, and our main outcome measure was that, well, we are proposing, but what is the sensitivity, specificity, and accuracy of these criteria compared to color fundus picture alone in diagnosing, assessing activity, and identifying the complications. So this is nutshell kind of my last slide, which shows that if you want to make the diagnostic purposes, minimal imaging set actually outperformed in mutes, AMPI, and birdshot. This was very valid. If you want to look at the activity, minimal imaging set allowed participants to achieve better results in all non-infectious except AMPI. And identification of complications was tested in serpiginous, multifocal, and PIC only because mutes doesn't have these complications, and minimal imaging set outperformed. In simple words, like if you are looking for CNV, you can't diagnose it on a color photo, you need OCT, angio, that kind of outperformed. So most interestingly, the minimal imaging set was very helpful in simple, straightforward cases. But in cases which were complicated or which are atypical or where you are not sure about the diagnosis, you may need MMI, multimodal imaging, you may need ICG, you may need everything. But if the case is straightforward, you don't have to do everything for everybody. For making the diagnosis, for accessing the disease activity, or for looking at the complications. So this was the validation exercise which confirmed the utility of most of the proposed MIS, and they increased the ability of ophthalmologists to diagnose and manage most cases of white dots, which are now non-infectious posterior uveitis, and this has nothing to do with the physician's background and clinical setting. We at IUSG are very, very mindful of the discrepancies we have in the world and the access to the imaging technology available. So we found that there was no difference. You could be sitting in the top-notch university or a dispensary somewhere in Sub-Sahara. These criteria we found were comparable in both the settings. A complete MMI approach is needed for more challenging phenotypes, and the moral of the story is that you don't have to feel discouraged that since you can't do everything, you can't diagnose. You still can diagnose in majority of the cases. Thank you very much for your patient hearing.
Okay, up next, Professor Mark Desmet, looking at natural course and complications to look out for in non-infectious posterior uveitis.
Well, thank you very much. Thank you, Vishali and the IOSG. I think you've had a very nice set of presentations that were given to you about the minimal imaging set and how to diagnose many of these flex syndromes that we see in the posterior pole. So I wanted to broaden it a little bit since we're talking to comprehensive ophthalmologists and maybe show you a slightly different way of looking at posterior uveitis. And just to start off, I think it's good to remember that there are about 40 to 50 different syndromes or presentations of uveitis, and probably the majority, how do I advance here? The majority of the cases you're going to see are anterior segment in about 80% of cases. And while most of those can be treated with just anterior segment drops, they can present with some posterior segment manifestations. In particular, if you're doing wide field, you'll be able to find some vasculitis in the periphery in a large number of individuals. But in practice, what you're really interested in is the amount of vitritis that is present, or the development of cystoid macular edema. And if that's present, obviously you have to treat it accordingly. Now, if we group the posterior cases, you've heard about many of these white dot syndromes or flex syndromes that we've talked about, but there are also some other conditions that may affect the retina. And so I like to separate them into the ones that have vascular involvement, the ones where we see granulomas as being a hallmark, and the ones that have flex syndromes. And all of these can lead to cystoid macular edema, glaucoma, and in the case of vasculitic problems, they can lead obviously to atrophy. And if we have granulomas, and you've seen some of these cases already presented where they involve the RPE, the deeper retina, the ellipsoid zone, as these lesions persist and respond or disappear on their own, they will often lead to a zone of atrophy. And so with vascular involvements, you want to see where they are, which vessels are involved, if it's just the retina or the choroid, and you need to have some idea of where you are in the disease course. Has it just started, or are we looking at types of recurrences? And the inflammation itself may lead to either retinal hemorrhages, cotton wool spots, the presence of exudation. It may just involve the posterior pole. It may involve the microvasculature or larger vessels. And in all of these cases, you're also interested in looking at the optic nerve and the presence potentially of some edema that is developing the macular area. So multiple sclerosis is a common disease, at least in our part of the world. The macula often is not all that involved. We'll see peripheral lesions and also involvement of the optic nerve. This is very helpful in terms of diagnoses. The disease itself sometimes can be granulomatous in the anterior segment, and accordingly you want to treat the whole patient, that is systemically as well as the eye involvement, either topically or with local treatment. Now, this is something we've already talked a little bit before. I don't think you'll see much of it here. We see it in the Western countries, in Europe and America, mainly in white patients. This is birdshot. It has a very subtle type of appearance, and in fact, it is a vasculitis because it involves both the retina and the choroid. And that's why Vishali mentioned that in trying to make a diagnosis, it's important to look at the ICG as well as the fluorescein. ICG may show you some granulomas that are accumulating inside the choroidal area, but it will also show you both early leakage, and also you do not see the vascular detail in the later phases of the ICG when you have a very active disease. Patients often will complain of having some degree of nyctalopia and some degree of vision loss, although early on you see very little inflammation inside the eye. But it is active disease that requires active treatment, and the difficulty with this particular disease is that you don't really see that much clinically, and unless you treat, the patient may become blind in about 10 to 15 years, but with treatment they do rather well. Behçet's disease, I'm sure you're very well aware of. It is an acute inflammatory disease. It affects both veins and arteries. And the big problem is, in fact, recurrent disease that ultimately will lead to loss of function, particularly in the macular area. And here, wide field imaging can be particularly useful in terms of follow-up. We also have idiopathic retinal vasculitis, where we don't find any other cause. And it is often associated with lack of vasculature around the macula, which ultimately will lead to some loss in vision and macular edema. Here's another case of idiopathic vasculitis involving the periphery, giving you macular edema as well as the optic nerve. And I think this is a very useful image that gives you, at least when we're talking about any kind of disease in the posterior pole, we want to make sure that we've eliminated mimickers that can be, for example, retinitis pigmentosa, the fact that we may have some infections, and then we have some common and less common diseases that can affect the eye itself. Some are more associated with a venous involvement rather than a arterial involvement, and these are, for example, sarcoid, birdshot, pars planitis, and Behçet's. Granulomatous diseases, again, one of the ones I'm sure that you see is VKH. Granulomatous, it tends to affect Asians much more than we would find them in Europe. Very much present in North America also, third or fourth decade. And it has both extraocular and intraocular manifestations, and a prodromal, acute, as well as a chronic phase. And in the chronic phase, what we see is involvement more of the anterior segment, although we can see recurrences in the posterior pole. And here I think doing angiography is useful initially. You will see first serous detachments. You'll be able to see these starry sky inside the retinal circulation when you do a fluorescein, involvement of the optic nerve. But for both diagnosis and follow-up, the use of the OCT is particularly useful. In the acute phase, you'll be able to see the appearance of, inside the serous detachments, these sort of membranes that are present. It's a highly, it contains a lot of protein and they tend to deposit. You see choroidal thickening, and if the patient is treated aggressively enough initially, the choroidal thickening will disappear, and that is a very good sign of good response to treatment. If, on the other hand, you see the patient late, the choroidal thickening will not disappear all that quickly. It may also persist for a long period of time. And in certain lesions, you'll see also what was described by Sapnais, the presence of these involvements of the outer segment and the ellipsoid zone overlying the areas where we see the choroidal thickening itself. There is depigmentation in the periphery that starts fairly early. It progresses more centrally if it isn't being treated. Ultimately, the person has a sunset glow fundus. But it can be stopped. It's very well seen on a wide field imaging, so I get this on all patients that have, in fact, VKH. And is one of the early signs that, in fact, you're getting good response also is the lack of progression of this depigmentation. In the advanced stages, you can see what it looks like. We also see a lot of these white little spots that appear that correspond in sympathetic ophthalmia to Dalen-Fuchs nodules. And if you image through these, you'll essentially see in the active lesion, just as in PIC, an area of involvement inside the outer retina, while once it quietens down, it just gives a zone of atrophy. Late stages, we also see some neovascularization that can appear, and these are difficult cases to treat when we reach that stage. This is typical of sympathetic ophthalmia in the early stages, so it looks a little bit like PIC, but of course the history is that there was trauma, either surgical or from another cause, and it tends to give you a granulomatous response. If you can treat it very early, aggressively, just as for VKH, you can stop this process. If you end up having to treat them later, they don't do quite as well, and they develop neovascularization in the macula, very often not directly associated with the presence of these lesions, and you also get atrophy around the optic nerve, as you can see here. And multimodal imaging can be useful here. Again, you can see these in the early stages, similar to what we saw with VKH, high content of protein as well as membranes that develop. And you see these lesions that are active that involve the RPE, the outer retina, as well as the choroid. And in a more advanced stage, it will just give you a window defect. Sarcoidosis, of course, is a granulomatous disease that presents in many ways. Classically, you can assess the degree of involvement by doing a fluorescein. I think that still remains very useful. But what is also useful is to get autofluorescence. It can give you an idea of where some of these lesions are present. Look for macular edema. And you should be able to identify choroidal lesions, granulomas, by doing EDI. And their disappearance with treatment allows you to know whether your treatment is being efficacious. You can also see some hyperreflective dots that correspond to inflammation inside the retina and the choroid, although you have to be careful that you're not looking at, for example, this lesion, which is a small vessel. These are recognized by the presence of an area of shadowing behind them, as well as their size, which is bigger, beyond about 40 microns when looking into the OCT. Now, granulomas you can image. You can see them both with regular photography by doing ICG or by doing EDI. The ICG doesn't necessarily correspond to the resolution of the lesion itself. That is better seen ideally by doing an OCT, as you can see in the image on the right, but you can also monitor it fairly nicely if you can get a full color picture, not the false colors that you get, for example, with Optos or with some of the either Heidelberg and other systems. Now, you've heard a lot about our flex syndromes. We can get some very good imaging, as you've heard from Eudes. Using autofluorescence is probably a good technique in order to be able to see what's going on. You can also see it on OCT by reconstruction, where you're able to see in a en face image the presence of all of these lesions. And what, of course, is great with Eudes is that it resolves over time, and you can help the patient understand what is going on by repeating the imaging at a future date. This patient here is a patient that doesn't quite meet the standards that we've discussed. We've talked about PIC, multifocal, and indeed, when she first presented, she had a lot of peripheral lesions. Yet later on, when she came a few years later, she started to develop these lesions along the vessel, and also what we're seeing here more centrally close to the macula that started to progress. And so, as Vishali said, both ICG and the fluorescein don't necessarily give us much information in terms of the area of activity. Autofluorescence was best, and also OCT, because it shows you the zone of involvement at level of the outer retina and the presence of macular edema in this case. And this patient, after some time, finally agreed to being treated with more aggressive approaches using biologics. So in conclusion, the eye responds with final common pathways in terms of, and this can be macular edema, glaucoma, scarring, as we've talked about, and the presence of atrophy. It's good to be able to recognize these key syndromes by key manifestations. So it's either the image itself, as we've been talking about with the flex syndromes, or otherwise trying to identify certain of the processes, that is vasculitis, the presence of granulomas, or changes in the retina. Knowing where the lesions are located and their evolution, and in particular with the OCTs, is recognizing the involvement inside the outer retina, whether there is in fact a haze that is present within the outer the ellipsoid zone, or the presence of atrophy. This can help with the diagnosis as well as being able to identify response. And I think if you see one active lesion, this patient requires treatment, and that's in fact the name of the game, is to be able to recognize those particular conditions. And multiple imaging can be useful. There's a minimum set, and if it doesn't seem to give you the necessary answer, you essentially have to do more imaging to get a better idea of whether it's active or whether you have an inactive situation. Thank you.
We have one more talk by Alessandro Invernizzi, who is not here, but did send in a recorded talk. And are you guys able to play it now?
Good morning, everybody, and thanks to the organizers for inviting me to give this talk at this prestigious meeting. These are my disclosures. Let's start with a bit of background. We all know that the SUN working group gave us recommendation to grade intraocular inflammation in an agreed on grading cells, flare in the anterior chamber, and vitreous A's. And they gave also these sort of scales to refer to on the. Good morning, everybody, and thanks to the organizers for inviting me to give this talk at this prestigious meeting. These are my disclosures. Let's start with a bit of background. We all know that SUN working group gave us recommendation to grade intraocular inflammation in an objective way, and they agreed on grading cells, flare in the anterior chamber, and vitreous A's. And they gave also these sort of scales to refer to when we have to grade when we have to clinically grade them objectively. So we have cells in the anterior chamber, flare, and this is the scale that we are meant to use for the back of the eye. Now, all these scales remain the current paradigm for uveitis assessment, both in clinical trials and routine clinical practice till nowadays. But they suffer from some limitations. So they are subjective, they are non-continuous, and there has been shown that there is low agreement between two graders rating the same patient on the same day. So there is a bit of difficulty even if they are meant to objectivize the information. And this basically tells us that we need better outcome measures both in routine clinical practice and clinical trials to assess intraocular inflammation in patients with uveitis. For this reason, groups of experts have tried to tackle this problem over the years with the aim to find objective measurements better than those we have already now. So we basically we are in front of two possibilities. We have new biomarkers to look at, or we have better ways to measure old biomarkers. Now, the good point of looking at these last ones, so better measures of old biomarkers, is that we already know that these biomarkers work. We just need to be more precise in measuring them. And then we have new biomarkers. So we'll start with the old ones and then we'll move to the new ones. So as I said, better ways to grade something we already know is reliable in giving us an idea of what's going on in the eye. And the OCT in this plays basically a revolution. So we are now able to assess the number of cells in the anterior chamber with the anterior segment OCT, and this has been proven since 10 years now. This is the first paper on ophthalmology showing this, and then this is another one more recent where we were able to assess both anterior chamber cells and flare using an anterior segment OCT. This can be also applied to the vitreous. So back in 2014, the group from Moorfields proposed to look at the reflectivity of the vitreous, so the haziness of the OCT scans, to objectively correlate this with the haziness of the vitreous, so the vitreous inflammation. And this somehow works, but is also highly affected by media clearness, so this never really was implemented into clinical practice. More recently, we focused on cells rather than haze, and we found these cells in the vitreous to correlate way better with the clinical grading and to be much less affected by media opacity. So you see how the number of cells gradually increases with the different in IA clinical grading, and while the vitreous reflectivity doesn't really fit so nicely with the clinical grade. And this is just a scale to show how cells can vary in different grades of vitreous inflammation. The same can be applied also for anterior vitreous using anterior segment OCT and just pushing the head of the device a bit forward closer to the patient. Now, all these are, the ones that I just listed you are better ways to assess old biomarkers, so cells. And these can work regardless the kind of uveitis. But here we are focusing more on non-infectious posterior uveitis. So we have to look at specific features of these diseases. And for these, we need new biomarkers. Now, the pro of new biomarker is that it's an innovative way to look at the problem. It allows us to measure new things that are potentially better than those generic old biomarkers we looked at so far. But on the other hand, they need to be validated and they're not necessarily accepted by regulatory agencies. So we have to work a lot to implement these into the clinical practice. So one, and probably the most widely accepted both in clinical routine and clinical trials, is macular edema. Now we know that OCT to assess macular edema is probably the best way, and this has been already proven by several trials, several studies, and not all the non-infectious posterior uveitis have macular edema, but first, for example, birdshot chorioretinopathy can have it, and definitely this is a good way to objectively measure inflammation in this disease. Another way to assess inflammation in posterior uveitis is to look at choroidal thickness, and we know that the choroid gets thicker regardless the entity we are looking at, because it's kind of a non-specific biomarker for inflammation in the back of the eye. And the number of papers looking at this is been increasing in the last few years. So this is something we should always look at when we look at posterior uveitis, and non-infectious posterior uveitis are not an exception in this case. There are also more complex ways to look at the choroid and its activity. One of these is the choroidal vascularity index, which is the ratio between the lumen and the stroma of the choroid. And you can see that increase in CVI is basically can mean larger vessels, while decrease in CVI is usually attenuation of choriocapillaris or reduction in the size of choroidal vessels. And obviously this can be used to assess the inflammation in the choroid and to monitor patients with uveitis. Another feature that is probably not unique of posterior non-infectious posterior uveitis, but can be present, especially, for example, once again in birdshot, is the leakage from vessels, from retinal vessels. And there are ways now described to objectively measure these leakage. As you see here, we can measure both hypoperfusion in the fluorescein, so hypoperfused areas and leaking areas. And here are some examples of automatic algorithms allowing to assess this and to monitor this over time. As you see, for example, in the first line here, we have a lot of leakage, and then as the leakage decreases, the algorithm is able to catch this difference and to measure it objectively. Now, if we think about one of the most important infectious posterior uveitis, we know that APE shows these creamy lesions, and we know that this basically is related to the fact that we have hypoperfusion of the choriocapillaris. And this is nicely showed by ICG, which is however not always available, but is also very nicely showed by OCTA, as far as we place the slab of the OCTA at the level of the choriocapillaris. So we have these hypo-reflective areas which basically demonstrate the hypoperfusion of choriocapillaris, which is responsible for the damage in this disease. And we also know that we can track these changes over time. So for example, in this patient who received steroids, we can see that the hypoperfusion decreased from baseline to the last follow-up, and we can see that OCTA is able to demonstrate the change without need to repeat ICG. And obviously we can track these changes over time, and we can measure these areas of hypoperfusion and see how they change, increase, decrease, disappear, and this can be used as a guide to the treatment in these diseases. Obviously, measuring choriocapillaris is a bit of a challenge because the segmentation lines the automatic segmentation can fail due to the damage of the standard anatomy. and the clumping of pigment on top of them. So always be careful and look carefully at these lines where they are placed, and if there is any misalignment, just adjust it manually before using these images as a reliable tool to measure hypoperfusion. We also know that this hypoperfusion is often accompanied by alterations at the level of the outer retina, which is actually what gives us the disturbances in visual acuity. And some researchers have looked at these alterations of the outer retinal layers on unfast OCT. So this is another nice way to look at the alterations in the outer retina and in non-infectious posterior uveitis. So this is one paper, and this is another more recent paper looking at this hyperreflectivity in the outer retina and measuring it, and this very well correlates even better than choroidal hypoperfusion with visual function. So to conclude, we have objective ways to assess the intraocular inflammation, and this is mandatory for proper management of patients with uveitis in general. And regarding non-infectious posterior uveitis in particular, we have new imaging techniques that can be applied to better measure the alterations in these diseases, even better than all the inflammatory biomarkers. But we need to work hard to standardize and validate these new techniques. And with this, I thank you for your attention.
Well, we have time for questions. If anybody has any questions for the various members of the panel regarding the presentations that were given so far. Maybe I'll start just by making maybe one or two comments. I think what Alexandro shows is what the future holds. The question is how well can we apply it today? And in some ways it also depends on how efficient the OCT machine is itself. And so there are new machines coming out with swept source, I think, that will make a big difference because they'll be imaging faster and allowing us to see more both in the anterior segment as well as in the posterior segment. But maybe one question for the members of the panel. We've talked about OCT, OCTA, using EDI. So at least we're talking to comprehensive ophthalmologists, is when would you use all of these modalities, and when would you in your practice today still want to do a fluorescein, because you're all saying we don't need to do it all the time. So maybe I'll start with you, Jennifer.
I tend to use fluorescein for retinal vasculitis. I will often get, even though we're talking about posterior uveitis, I might get fluorescein, a wide-angle fluorescein angiogram for somebody with either MS-associated intermediate uveitis or even prosoponitis, to get an idea of whether or not there's involvement of the vessels. I also like fluoresceins for birdshot, because you can see birdshot tends to affect the choroid, but also the retina, particularly the retinal vessels, and those two aspects of the disease can work together or completely independently, so it can be very helpful to see both of those to sort of assess activity and what you need in order to treat.
Any other comments? Because the other question is when do we repeat fluoresceins? Because it's nice initially, and whenever there's a doubt, and whenever you're not sure that your OCT or your other imaging modalities are giving you enough information, fluorescein still remains a very good technique. But when should I repeat it? Sapna?
I can take that. So I'll usually do, say for example, the diseases that Dr. Thorne mentioned, like vasculitis or birdshot, I would do an FA at diagnosis. Then I initiate treatment, and then maybe about 3 months after treatment, I'd like to repeat the FA to see how that is working, make sure that the patient is improving. I may not see complete resolution yet, but I don't want to see worsening. And then after that, I monitor the patient every 3 or 6 months. I'll repeat an FA again to ensure that the treatment is optimal. Once I start to taper medications, again, I will probably do it after I've taken the patient off all medicines. Intermittently, once every 6 months, I will do an FA to confirm that they remain quiet.
And do you use Whitefield or do you
Yes.
use a standard? And
I use Whitefield.
is it always necessary? Because, it's not everybody has a Whitefield. Does it really give us that much more information?
I'd say it's regional because my photographers, they don't know how to do a good montage anymore. So I don't really see a good montage. And there are times when I go to the satellite clinics and they don't do good imaging. So for my convenience, I do an Optos Whitefield.
To add to what Sapna said, she said she would do it after stopping the treatment. I would, like Jen said, for my vasculitis, for my pediatric patients, I'm very fond of doing fluorescein still in all the children. I mean, to look at the leakage, TINU, Blau, JIA, even presumably JIA. But I repeat fluorescein when everything looks very fine to me and I want to put them off the biologic or immunosuppression, but that's the time when I want to know how much is the minimal residual disease I still have, so that if there is an aggravation of the disease after stopping the therapy, I have the thing to compare with. The second scenario where I repeat is some of our patients with TB and Behçet's who are quiet, but who start, who have the risk of developing new vascularization. So the patient has a minimal bleed or new vascularization, and you want to identify those areas of capillary non-perfusion, which you would selectively laser. I would do fluorescein. Other than that, I don't think we need to repeat it for anything. I mean, I might have missed out, but not in routine practice.
I think it's a good point that, if you're going to stop therapy, just to have a baseline and be sure that you've reached a level of quiescence that allows you to do it. Because whenever we stop medication, there's always a risk of recurrence. And, particularly with biologics, within the next 6 to 12 months, you have about a 40 to 50% chance of having a person develop a recurrence that will require treatment. And if you reinitiate the treatment, then later on you have less chance, but it's not an all or none phenomenon. What about OCT? We've talked about EDI, and we've talked about OCTA also in some of our talks. When do we need EDI, and when should we use OCTA? Jennifer?
I tend to use EDI mostly for research purposes or VKH. Occasionally I will use it for sympathetic ophthalmia as well. You can kind of glean whether or not your patient is about to get into trouble if you see sort of an increase of choroidal thickening in VKH where the rest of the eye looks reasonable. But it may give you a clue, and it's fairly easy to do and non-invasive. OCTA, I don't have a readily available in my clinic, so I have to sort of send the patient to the second floor to photography, which probably means that I use it a little less frequently than maybe I would otherwise, but often that's to distinguish a lesion where I'm concerned about choroidal neovascularization in the macula, and I want it as a confirmation.
And I think the problem also... oh, yes. Go ahead.
Just have one question. I have seen patients with maybe retinal vasculitis due to Behçet's. Clinically, they have become quiet after the treatment, and we repeat the FFA. And surprisingly, we see minimal vascular leaks, especially in the periphery. Clinically, it looks very quiet. So my question is, do we continue treatment? There's no CME either, or do we stop the treatment?
I would like to take up this question because this is a very relevant question. If you ask me, like a decade early, we used to talk about zero tolerance for inflammation. And now, either we are old or, I don't know, at least I talk about the tolerance for inflammation, tolerating a minimal residual dose. I do not have a scientific answer, but based on my experience, I compare it with the baseline. One should not be in a hurry to stop. So the standard endpoints are you have waited for 2 years of a quiet disease, the disease looks quiet, and now you want to stop the immunosuppression. So I compare it with the baseline, and I see there is a significant improvement. Vision is good, there is no macular edema, there is no hyperfluorescence of the disc, but some capillaries in the periphery are, I do not know whether they are leaking or it's just the hyperfluorescence, but some white areas are there. Now those areas currently are not the criteria for me to continue the treatment. I will still stop if I'm convinced that this patient does not need. When you stop the treatment, and like Sapna said, you might repeat it after 3 or 6 months, you will find there will be some increase. Now, is that increase a reason to restart? To me right now, not really. I still look at the macular thickness. Is that peripheral leak affecting the macula, or the disc, or the vision, or the floaters, some cells somewhere? If none of them is there, that's still not a reason, but I might keep the patient under closer follow-up, explain to him to come to me if there are any symptoms, but that is the answer IUSG is looking for. Eventually, maybe 1-2 years down the line, we want to have a scoring system that we give scores to the kind of the different symptoms, and we say, well, if you have the score of 50 and below, tolerate it. If you have above, treat it, but we are very far from it as yet.
The other thing with Behçet's is it's a very variable disease too. I remember that Khalid Tabara was telling me that, for example, in Saudi Arabia, they had patients that had 1 or 2 events, and they would stop treatment and they would have nothing for another year or 2. And there were others 3 months later that had a significant flare-up. So you have to adjust also in terms of how frequently they have flare-ups, independent of what we're seeing with our imaging. And of course, the degree of ischemia, as Vishali was mentioning, is very important. If there's ischemia in the periphery, there'll be more leakage from those small capillaries that we have peripherally.
I want to follow up on this and ask Vishali this question. So there are 2 aspects.
You need to turn it on.
There are 2 aspects to the question. One is, when is disease mild enough or stable enough that you can come off treatment? And second, to follow up on what you asked, Vishali, I'm going to ask you, what is the trigger for us to escalate treatment when we are continuing to see leakage?
We do not have the answer yet, but for me, that leakage has to produce some kind of visual problem. If the macular thickness is increasing beyond 300, if that leakage is causing something, the cells in the vitreous, the vision is less than 612, I would just escalate the therapy like that. If everything is quiet and there is just some leakage, currently I do not increase the therapy. I keep them on, I do not take them off the therapy, I keep them on the same, and I wait for the things to worsen, which in 60-70% of the time they do not worsen. So I do not want to treat everybody.
Might be a good time to use a wide-angle visual field. If you think about some of the data that suggests that if you have chronic leakage and intermediate uveitis, you have depression of ERG, or if you have birdshot with low levels of activity in the retina, you can see it, you can measure it by using a P60, an octopus, a Goldman, you can see constriction of field. That may be one way you could address a little bit of that.
Birdshot we don't see.
That peripheral leakage, yeah.
Absolutely.
Is the choroidal thickening standardized for uveitis? How do you exactly measure? Because most people will have the ordinary OCT, where the choroidal thickening will not be possible to.
So on the OCT, if you have the Heidelberg machine, you can set it so that you get a choroid. You set it for the outer, the RPE, as being the focus. It's called EDI, And it allows you then to look at the choroid in its full thickness. And it's essentially it's a measurement that you, by looking a little bit as I showed you, the thickness of the choroid, and it's best to do it prospectively to see that it remains the same or decreases in size. And as Sapna also showed, if you have a case where you're able to see the choroid, the patient comes back and it looks thicker, and it was imaged in the same location, that thickness probably indicates that there is inflammation present.
With the SD-OCT, is it possible, sir?
Sorry?
Is with the SD-OCT, the ordinary, not the SWEP source or the EDI-OCT?
So the SD-OCTs do, yes, yeah. Spectral domain can create.
You can do EDI.
Yes, yes.
It's technical.
Is it possible?
Yes, it is possible. It is.
Digital calipers are there.
It's just technical. Your imager has to, like, it's almost like if you want to, you push it behind and your focus is behind.
You have to move closer to the cornea, though I don't do it, but technically if you move it forward, at certain point the OCT image kind of flips, and that is where you start seeing choroid very clearly. That is, EDI is on spectral domain only. Swept source is very different. That will show you choroid right in the beginning. When we talk about enhanced depth imaging, that is applicable to standard swept source OCT. You just have to move it closer to patient's eye.
And in addition to what was said before, I think it's useful anytime you think there is a choroidal granuloma, because you can image that on EDI and you can follow its progress with treatment, its disappearance with treatment. Any other comments? Or with regards to OCTA, I think one of the problems is also the quality of the machine. And so some of the newer machines give you good images, and while it can help you in seeing some of the deeper layers, it's very useful in retina. I think, you know, when I look at it for uveitis, it's useful if I think there may be a neovascular lesion. If I'm able to see it with the EDI, well, then I can follow it. But most of the time when I try to image it, I don't see it. So it's, I would say maybe in 30–40% of cases it may be useful. And in all the others, even fluorescein, very often we don't see it because they're small, and you end up having to treat essentially on your acumen as a clinician. I don't know if any of you have other experiences, but that's mine personally.
I can add to that. So sometimes you'll see a little neovascular membrane and it's inactive. It also will be seen. So usually, even though we see it, I use it to monitor if it is growing. But unless there is actual subretinal fluid, I won't initiate an anti-VEGF injection or something at that point. I'll just monitor. So I use it as a monitoring tool. I don't do OCTA as often. I'm still learning my comfort with it. And again, I will acknowledge my privilege. We get, in the US, it's very easy to get a lot of imaging, so I think we over-image a lot. And so I don't think it's essential, unless you're in doubt, to get an OCTA or an OCT.
I do have subset of patients, especially after serpiginous choroiditis, who complain of metamorphopsia. So when you look at it clinically, it is inactive. You do OCT, it is inactive. Autofluorescence is inactive, but the patient says there is metamorphopsia. Now, those are the situations I will do angio-OCT, and if I see new vascularization and the patient is symptomatic, even if there is no fluid, I will discuss with the patient. Because many of these patients actually come from different parts of the country where they have been told to increase the immunosuppression. So I think, to me, it's very important that the symptoms you differentiate due to CNV from the recurrence of choroiditis. And if OCT angio shows a new vascular network, I discuss with the patient that I'm going to give you one injection. I don't know whether it will work or not. If it works, good for you. If not, at least we have tried. And it works. And contrary to AMD and diabetes, you know, sometimes just one injection is enough for many of these patients.
Particularly if it's in combination with immunosuppression.
Yes. Absolutely.
Yeah. We're going to have to close. Are there any more questions? Otherwise, I think in the name of everybody here, Vishali, the IOSG, and I'd like to thank you for your presence here. And if you have any more questions, we'll wait at the very back. Thank you.
Thank you very much. Thank you. Our next session is also next. Juan is coming. We will meet Juan at 1. Ah, okay. I thought. What is this? Red brick? This is for you. It's yours. I don't know. He's saying it's yours. Yeah, first we'll open it. First we'll open it.
Yeah, and then
No,
you decide not to take it.
Okay, let's take the picture. You're so cute.